All right, good. Thank you for that chat function there. And you can ask questions on here as well, okay? So um, I'm currently at my work in the hospital here. So I usually have an excellent, fabulous internet connection. Not sure what happened if they reset something, but if anything is lagging for any of you or Mike Stewart, let us know. Let me know. Um, that's what uh, troubleshooting will go with. Hopefully not though. But anyways, let's get started. So welcome back from lunch and welcome to your first day, everyone here, and thank you for being part of Osler's here. I know it's a lot on your agenda for the next several days for your test. And as you see from the schedule here, we're trying to cover every topic we possibly can to get you a thorough amount of of education to get through this test. So I've got you for the next three lectures here, and we worked in coordination with the other faculty members to try and minimize the amount of repeat topics. There might be some overlap for sure during the next several days, okay? So this first topic is going to be minimally invasive and metabolic surgery. It's a tough topic to go through in just 1 hour, but we'll be as efficient as possible. As always here, please type in any questions under the chat function, okay? We'll try to get to as many of those as we can with respect to time. I'm Andrew Wu. I am a general and bariatric surgeon. I've been in practice for about 14 years, and I've been teaching Oslers for a majority of those years, actually. And I also teach the oral board component too as well. And we're going to proceed. All right, so intro to MIS. So in the last 15 years, there have been an exponential increase in the drive and development of MIS technology, specifically the robot as well. Obviously, this is going to be effective in terms of increase in safety, patient outcomes, smaller incisions, quicker recovery times, decreasing hospital length of stay. All goals are to decrease trauma for the patient while achieving overall goals of the surgical operation. And essential principles of laparoscopy will obtain safe access into the abdomen, establish pneumoperitoneum with 12 to 15 millimeters of mercury of pressure using CO2, trocar placement under direct vision, triangulating the organ to be operated on. Always be prepared to proceed to an open procedure and always be cognizant of the physiologic effects of laparoscopy on the body. And there will be a couple of questions that they like to ask specifically with regards to the physiologic effects, which we'll get to in several of these slides here. All right, and I'm going to try and integrate questions throughout the talk too, just to be able to give you some example questions for the test and to keep you all engaged. This is a chat function. You don't have to type in the answer. You can just think of it in your head if you'd like. Which of the following conditions represents a contraindication to advanced laparoscopic operations? A, pregnancy. B, morbid obesity. C, contraindication to general anesthesia. D, previous laparotomy. E, cirrhosis. If it's C, you are correct. Contraindication to general anesthesia. So certain contraindications to laparoscopy. High-risk ASA4, not ideal candidates. They may not tolerate pneumoperitoneum. Previous contraindications, which now are becoming much more readily acceptable. Morbid obesity, previous abdominal surgeries, pregnancy, early cirrhosis. And so I have a lot of these videos here, and this is a video I took of gaining access. And I want you in your minds right now to think of everything that's happening in this video, and in your mind think, is that what you would do? Is there anything incorrect or wrong, or is there anything that's actually okay to do, but maybe it could be done safer? You can see the numbers there. You've got varus needle action in the midline. The surgeon has chosen to use a towel clamp as an effective means for providing entry access. You've got blind insertion of a trocar. All right, that concludes that video. So now, if you were all live with me like we did before COVID, it'd be nice to be able to engage you all and talk and just kind of open the field up to you all and ask, hey, let's have a discussion here. What's right about this? What's wrong about this? Do you like what this surgeon did? Would you do the method of entry like this surgeon did in this video? Yes or no? And so hopefully that you've been able to see this and think that this might not be the safest way of entry. So which of the following is not an appropriate technique for initial trocar placement during laparoscopy? A, varus needle insufflation, followed by blind trocar placement. B, open placement of a Hassan cannula with C, optical. D, blind out pneumoperitoneum, or E, all of the above are acceptable. And if it's D, you are correct. So getting access to the abdomen. So there's really two types. There's open access and closed access. If we talk about open access, that's fairly straightforward. Cut down to the open fascia, a trocar. Then you've got various types of closed access, of which you did see one here. Varus needle, then blind trocar, varus needle, then optical trocar, no varus, optical trocar, no varus, blind trocar. So which of those might be the best? Which is the way that you do them? And I think that we can all kind of agree that no varus and blind trocar is definitely not really safe and acceptable. Speaking of varus needles, let's talk about that. Needle is 12 to 15, well, it's not meters, but centimeters long. A spring-loaded inner stylet with a beveled needle tip. The tip is dull. First described in 1938, an Hungarian internist working with TB